Ma'am, you can start the meeting.
Sudha?
Yes, ma'am. Good evening, everyone, to the respected seniors, delegates, and the speakers. And we have successfully entered into the 4th online monthly SFM Telangana meeting. And today's topic is about the diaphragmatic defects, where we are realistically upon antenatal detection and postnatal correction. I would like to invite Dr. Chinmay Ratha ma'am, SFM Telangana President, to give a welcome note and also to invite the respected seniors, Dr. Mohit Shah sir and Leela Kumar sir, to moderate the
Dr. Mohit Kumar Madhan office.
To moderate the case discussions for the day.
So thank you very much, Sudha, and a very good evening to all of you who have joined on this third Wednesday evening, which has become our monthly academic meeting of the SFM Telangana. Dr. TLN Praveen sir, our senior most SFM member from Telangana, is always there to encourage us through this. And sir, thank you very much for being with us always to hold our hands and let things go on. As Sudha said, we are entering the 4th academic meeting here, and we've had very interesting discussions in the past. In fact, the discussion on the fetal phase last time was really thought-provoking, and we have to do a part 2, which we will do subsequently in due course. Today, we have chosen a topic which is a very structural defect, and the entire onus on the prognostication, diagnosis, and postnatal management depends on the clinician. So the fetal medicine specialist has to diagnose this correctly, prognosticate it correctly, have a good alignment with the postnatal corrective team, which is headed by the pediatric surgeon. And therefore, we have a very good, combination here where we have all the senior fetal medicine people and a senior pediatric surgeon who will be guiding us through the discussion. So I welcome Dr. TLN Praveen sir, Dr. Bimal Sani sir, and Dr. Mohit Shah sir into this program. For the first session, I request Dr. Mohit Shah and Dr. Leela Kumar to please be the moderators of this session, where we have 2 of our young doctors presenting the cases. One of them will present a case on eventeration of the diaphragm and the other one on congenital diaphragmatic hernia. And then we will take the discussion on how to simplify the diagnosis and make a good plan for postnatal correction. So Dr. Mohit Shah does not need much of an introduction, but it would be great if we could display his CV here, because he's one of those quiet persons who does not, make a lot of noise here, but does a lot of noise with the work that he does. And he works in Mumbai, is the vice president of the SFM team, and has been a really, really strong pillar of the Society for Fetal Medicine.
Sorry, he is the president-elect.
Is the president-elect now. So as I said, every time the noise becomes bigger and bigger with his work in the background. And I can't say that, sir, you did say it. And I know that he's an exponent in musculoskeletal ultrasound, that I can say, because I have seen him sometimes diagnose some of these ligament problems and joint problem, where I feel we cannot see anything at all, but he's one of those who can make those differences between the shades of gray. But that apart, he's been extremely active in disseminating the academic agenda of the Society of Fetal Medicine all over the country. And we look forward to your expert comments in this session here, Dr. Mohit. Very passionate teacher, and I'm sure you'll simplify it for all of us. Dr. Leela Kumar, I'm not seeing him here, but he is one of our ace pediatric surgeons here in Hyderabad, and somebody with whom we can very comfortably join in the antenatal period. Yeah, sir has also now opened this video there. So he is a very senior pediatric surgeon in Hyderabad, and we are very, very fortunate to have her on our team, because from the antenatal period, counseling the patients and then giving them a very good surgical outcome is completely in his hands. I call him a maverick because he really thinks of different methods of doing those surgeries, and he stands by us throughout the process in giving a good outcome to our fetuses who unfortunately have congenital defects. Thank you very much, sir, for joining us this evening. And I will hand over to Sudha to introduce the speakers of the first session.
Thank you, ma'am. The first case is by Dr. Navya. She's consultant in Resolution Fetal Medicine Center and Research Institute, Hyderabad, and her topic is abnormal curvature of the diaphragm. Dr. Navya, ma'am.
You stop sharing, Sudha, so that Navya can share her screen.
Yes, ma'am.
Hope everyone could see my slides.
Yes, Navya, just make it full screen, please. Yeah, excellent. Carry on.
So, good evening to everyone. I will start with my topic, abnormal curvature of the diaphragm, that is congenital diaphragmatic eventeration. So, my patient is Mrs. Izzat, 25 years old, gravid to previous one miscarriage, came to us at 26 plus 4 weeks in view of query left-sided CDH. Otherwise, the antenatal history was uneventful. Ultrasound done at our center. We had an ultrasound done. These were the axial views of fetal thorax and the abdomen, where we could see the. I got my slides and all. Yeah. The slide shows the axial view of the fetal thorax and the abdomen, where we could see the normally placed stomach on the left side of the fetal abdomen, and the heart is pushed to the right side. I mean, sorry. 1 second, please. Sorry, we have done an ultrasound at our center where we could see a normally placed stomach on the left side of the fetal abdomen, and a lobe of fetal liver could be seen on the left hemithorax, which is pushing the heart to the right side, that is juxtaposition of the heart with apex pointing towards the left. Otherwise, the external views of the heart were normal. This is another picture showing the axial view of the hemithorax, where the heart is on the pushed to the right side by the liver on the left side, where we could see the liver vasculature. And this is a coronal section where we could see the stomach on the left side, above which the liver could be seen on the left side, and the diaphragm is delineated entirely on either side. And we have made a LHR ratio, which was 65%, suggestive of a good prognosis. And this is a cine loop of the same case. Cine loop of the same case, where we could see a stomach on the left side, and heart is being pushed by the liver to the right side and apex towards the left. And this is the coronal picture showing the diaphragm on both the sides, and one side it's being pushed upwards by the liver herniation. So with this picture in the mind, and when we see normally the normal diaphragm will be a curvilinear hypoechoic structure which divides the thorax into thorax and abdomen, which is 2 to 3 mm in thickness, which will be on same level on both the sides. In contrast, in CDH, there will be a break in continuity, that is, it is not visualized on both the sides. In this picture, you could see only one side the diaphragm is visualized, on the other side it is disrupted due to herniation of the stomach and the intestines. In contrast, in our case, we could see the diaphragm on both the sides, that is, continuity is maintained, but not at the same level. The diaphragm is being pushed upwards on the side of the liver by the liver herniation. So with this kind of a picture, we had a provisional diagnosis of congenital left-sided diaphragmatic eventeration with no other gross congenital malformations, and patients were offered for MRI, which they opted out. And we explained about the condition, and we arranged for a consultation with the pediatric surgeon, after which parents decided to continue the pregnancy. And patient had again follow-up at around 32 weeks, where the fetal growth was normal, and LHR ratio was again taken, which was 65%, which was suggestive of a good prognosis. She delivered by a full-term LSCS at around 38 weeks and given birth to a live birth boy of 3.2 kgs. And postnatal X-ray mimicked a similar ultrasound, antenatal ultrasound diagnosis, that is findings of a diaphragm which is pushed upwards by the liver herniation, and the stomach air gaseous distension of stomach could be seen below the liver herniation. The same ultrasound findings of stomach, liver herniation and the diaphragm in this picture. So the pediatric surgeons decided to do a laparotomy on day 3 of life, where the diaphragmatic repair and strengthening procedure was done and baby was discharged uneventfully. This was the surgical picture where the plication of the diaphragm was being done. And at present, the child is 18 months old and he is doing well. So coming to discussion, eventeration was first identified in the 17th century by Jean-Louis Petit. After around half a century, the term was coined by Beckler in 1829. It took another 1 century to do a surgical repair by Morrison in 1923. This diaphragmatic abnormalities generally occur in 1/2000 to 1 in 5,000 birth, and it could be a herniation, eventeration, or agenesis. So by definition, eventeration means elevation of a part or a hole of the diaphragm due to lack of a muscular fibers, which normally arises into the thoracic cavity. It is considered as a defect because there is anomalous elevation allowing the invasion of the intraperitoneal structures into the thoracic space and compression of the intrathoracic structures. The pathophysiology is similar to that of a CTH. In contrast, the hernia is the disruption of a membrane, that is pleural or peritoneal membrane, with intact muscle fibers. So this embryology will be discussed in detail by the next speaker, but we should know that it is formed by the 4 structures, that is septum transversum, 2 pleuroperitoneal membranes, peripheral body wall muscle, and mesentery of the esophagus, giving a tendinous, muscular, and pleura of the diaphragm. So histopathologically, in eventeration, we can see a translucent membrane of up to almost a normal muscle thickness, that is 3 layers of its structure, and normal diaphragmatic insets. It can be classified as a congenital or acquired, and acquired types are mainly due to injury of the phrenic nerve, which could be due to inflammation or external trauma, and it usually results in complete diaphragmatic eventeration. The other acquired etiological factors could be a congenital infection, mainly due to toxoplasma or cytomegalovirus. It has also been reported to occur after the use of forceps during the delivery. So the CD usually is unilateral, rarely it is bilateral. It is most commonly seen in the right side, but in our case, it was in the left side, and it mostly occurs in the male infants. And this eventeration has long described in the pediatric literature, that is postnatally, in detail about the diagnostic testing and management. However, the prenatal description remains limited. There were only 10 published cases of prenatal diagnosis that was confirmed postnatally. In all the 10 case reports, the striking feature was that visualization of the membranous diaphragm on both the sides. The other features are non-displacement of heart in 7 out of 10 cases. There is movement of intestine along with breathing, that is paradoxical breathing, presence of high drops, abnormal location of the kidney in the thorax, which is usually uncommon with CDH, and the high diaphragmatic level varies, but this is not a specific criteria to define the condition. So these are the 10 case reports where they could see the membranes on, where they could see the membrane as a striking feature in all the cases. So as said, the prenatal differentiation between CDE and CDH by only sonography remains difficult, but because the two entities have similar sonographic appearances, MRI imaging can be given as an option, and it might be of additional value in identifying the diaphragm and confirming the diagnosis in doubtful cases. So seeing the main difference between the eventeration and CDH, in eventeration, there is a failure of muscularization of intact primitive diaphragm. That is, it is replaced by a thin membranous layer. So as such, there is no break in the continuity of the diaphragm. In contrast, in CDH, there is a failure of one or both ppm to close the canal, or failure of development of parts of the diaphragm. So as such, there is a break in continuity of the diaphragm, and there will be a communication between the abdominal and thoracic cavities. So the other features are non-deviation of the fetal heart, and changing location of the stomach in the different examination, that is movement of the bowel downwards with fetal breathing, which is called as paradoxical breathing movements. LHR ratio, which is used for the prognostication in CDE, which was not actually mentioned in any literature, but it is because the pathophysiology is similar to that of a CDH, it is used to prognosticate, and it is usually of a milder disease, but in CDH, the degree of severity may vary. Other minor features are presence of ipsilateral kidneys, presence of hydrops is seen to be more common with eventeration. The upturning of SMA, that is superior mesenteric artery, due to dragging of mesentery will be seen in both the cases. And because this CDE is usually present as a milder cases, it is treated conservatively. In contrastly, that in herniation, it often requires a postnatal surgery. So the associated findings are similar to that of a CDH, where it can accompany along with any cardiovascular, gastrointestinal, facial abnormalities, musculoskeletal system, genitourinary, chromosomal abnormalities, etc. The prognostic parameters is determined by measuring the lung volume by LHR ratio, how the measurement is made, and other LHR measurement is made and other measurements are made as discussed along with CDH, because where it is more appropriate, because a separate prognostic parameters are not well defined for CDE in the literature. Since the pathophysiology is same for both, the LHR is usually used as a prognostic factor and it is measured in the same way like we do it for CDH. The other prognostic parameters are when it is present with other anomalies like chromosomal abnormalities. If it is present with high drops, it has a bad prognosis. Associated with polyhydramnias, it has a bad prognosis. Cardiac ventricular size and gestational age at the diagnosis are all determines how the severity goes on. So because it is usually a milder disease, the LHR ratio is usually above 45, which gives around 100% survival. The mode of delivery could be a vaginal or cesarean and is purely based on the obstetric indications. And the postnatally, it can be confirmed by X-ray, where it appears as a linear radialism leaf with a marked elevation of the diaphragm. It can also be confirmed with CT, MRI, chest fluoroscopy, etc. The complication includes the mortality in CD is considerably low. In a study, they have seen that the mortality rate in case of eventeration in 4 larger studies is seen to be only 1 to 8% as compared to CDH, which ranges between 22 to 70%. And fetuses with diaphragmatic eventeration detected prenatally have a perinatal mortality rate comparable to CDH cases with similar lung size. But in postnatal series, it is mentioned as the eventeration has a less severe anomalies. The morbidity can include developmental delay, GERD, scoliosis, chronic lung diseases, growth retardation, etc. So the postnatal management include usually varies with that of a CDH because it is always because it does not always require surgery. In mild cases, conservative therapy consisting of elevation of the upper body and administering oxygen and prophylactic antibiotics is all what is needed. And in severe cases, intensive oxygen and ventilation and surgical plication is opted, and surgical approaches could be a eventeration, include thoracotomy, laparotomy, thoracoscopy or laparoscopy with low complication rate compared to CDH. Postnatal management, in a larger study by Viney et al, seen that only in 23% of patients with congenital diaphragmatic eventeration were symptomatic and required surgical repair. So the surgery-related complication in Deviation et al study, he had reported that there was no postoperative complication in 13 patients he had seen up to 1 year of age with eventeration, which was due to phrenic nerve injury. A study conducted by Schwartz and Filler have seen a pneumothorax as a complication in 1 of 6 cases where diaphragmatic plication was performed to repair the eventeration caused by phrenic nerve paralysis. Viney et al seen that 36% of children who underwent diaphragmatic plication had complication from surgery involving phrenic nerve palsy and breakdown of suture line, resulting in reherniation. So the recurrence risk in as such in eventeration, if it is isolated, there none is seen, and if it is associated with trisomy, 1% is the recurrence risk. If it is associated with any kind of a genetic or syndromic, it is 25%. So as such, take-home message is that eventeration is a failure muscularization of the diaphragm leading to an anomalous elevation, which allows the invasion of intraperitoneal viscera, that is into the thoracic space, and compression of the intrathoracic structures, as mentioned already. That is, its pathophysiology is similar to that of a CDH. That is, in simple terms, CDE is a functional defect and CDH is a structural absence of the diaphragm. Diagnosis, it is difficult to differentiate between CDE and CDH, but a high index of suspicion should always be kept in mind while diagnosing CDH, and CDE should always be a differential diagnosis while diagnosing CDH. The prognostication, management, association, etc. are same as that of a CDH, but in the milder forms. Thank you.
Thank you, Navya ma'am, for the very crisp and smart presentation. I would like to invite Dr. Mohit sir, and Shaw sir, and also Leela Kumar sir to give their expert comments over this.
This was a wonderful presentation, Dr. Navya, the most comprehensive presentation on diaphragmatic eventations. I mean, kudos to you for that.
Thank you.
I would just say that it is possible to differentiate the two easily if you can see the continuity of the diaphragm well. So that is a very striking feature that when you suspect an eventation, in fact, I would urge you to go on a higher frequency transducer so that you're more sure that you're seeing the diaphragm very well. And if you can see the diaphragm very well, you're sure that it is an eventation. So at times we use a C92 or even a linear probe to differentiate the two. And of course, as you rightly said, for the amount of elevation of the diaphragm, the compression is not much. So in these patients in eventation, generally you have good LHRs, and that's precisely why you have good LHRs in spite of the disproportionate elevation of diaphragm, which otherwise in CDH will have massive compression syndromes. So good presentation.
Thank you, sir.
There are some questions, but I think we'll finish the second one and then take all the questions together with the experts.
Okay.
Our second presenter is Dr. Revati. She's a clinical fellow in fetal medicine in Resolution Fetal Medicine Center and Research Institute, and her topic is CDH and embryology of the diaphragm. Dr. Revati, you can start.
Good evening, everyone. I'm Dr. Revati, doing fetal medicine fellowship in under Dr. Chinmay Ratta at Resolution Fetal Medicine Center, Hyderabad. Sorry, my slide. My patient, Mrs. A, 23 years old, primary gravida, 22 weeks, 6 days, married for 1 year, non-consanguineous marriage, otherwise no relevant past and family history, whose dating scan and NT were normal. She didn't do her first trimester screening, was referred to a center for TIFA. Her initial maternal assessment was normal, her general evaluation of the fetus was normal, except that her abdominal circumference was less than first centile. This is the axial section of the lower thorax, co-chamber view, which shows abnormal positioning of the intrathoracic stomach with heart and dexter position. This is a video showing caudal to cranial sweeping from the cord insertion. So the below video shows the normal visceral position. The above video demonstrates abnormal intrathoracic position of the stomach with the dexter position of the heart. This is a video which shows the course of the superior mesenteric artery. The below video shows the normal caudal position, course of the superior mesenteric artery. The above video shows the abnormal cranial course of the superior mesenteric artery. So the lung to head ratio was measured and a diagnosis of left congenital diaphragmatic hernia was made, and the patient was counseled that this is a case of left congenital diaphragmatic hernia with fetal stomach in the left thorax causing a massive mid-astral shift with heart and dexter position. So the dexter post heart causing compression over developing lung causing pulmonary hyperplasia. The ratio was 42.5, which is indicating a mild pulmonary hyperplasia. In utero treatment of fetoscopic balloon occlusion of trachea is an option, but currently this intervention is not readily available at our center. The prognosis of postnatal surgical repair of diaphragmatic defect depends on the residual pulmonary function and development of pulmonary hypertension, which leads to high neonatal mortality and to rule out chromosomal aneuploidies and genetic abnormalities, amniocentesis and cytogenic microarray and whole exome sequencing was advised. Pediatric surgeon consultation was advised. The patient deferred any testing and went in for termination of pregnancy. So the embryology is, before coming to the embryology, I will just explain the anatomy of the diaphragm for a basic idea. So the diaphragm, the picture A is the coronal view of the diaphragm, in which you can see the diaphragm extends from T5 to T11 position, and picture B is the inferior view of the diaphragm, which shows a both muscular part and tendinous part are present. So these are the four components which forms the diaphragm: septum transversum, lateral body wall, esophageal mesentery, and right and left pleuroperitoneal folds. During day 19, the trilaminar layer, which is ectoderm, mesodome, endoderms, are formed. At around day 20, the mesodome is differentiated into paraxial, intermediate, and lateral plate mesodome. The lateral plate mesodome further differentiates into parietal and visceral mesodome. The parietal mesodome, which gives rise to the diaphragm. So at around week 5, there is a space in between the septum transversum and the pleuroperitoneal fold, which is called as the pericardioperitoneal canal. This will be gradually fused by the growing septum transversum at around week 7. The difference between the fetal diaphragm and the adult diaphragm is that the lateral part of the fetal diaphragm in the fetal diaphragm is developed from the pleuroperitoneal fold, but in the adult it is usually formed by the lateral body wall. So definition is a developmental CDH is a developmental defect in the formation of the diaphragm due to failure of pleuroperitoneal canal to close by 9 to 10 weeks of gestation, resulting in varying degree of pulmonary hypoplasia, which is caused by the compression of the developing lung by the herniated viscera. The incidence is around 3 to 3.6 per 10,000 live births. Mostly it is left-sided, around 85 to 90%, followed by right side, which is 10 to 15%, and bilateral in 1 to 3% of the cases. 60% of the cases are isolated and 40% are syndromic. So the anatomical classification is broadly classified into posterolateral and non-posterolateral. Posterolateral is also called as Bockler duct, which forms an 80 to 90% of the cases, and the contents will be usually stomach, intestine, liver, and spleen. 85% of the cases will be left-sided, 10 will be right-sided, and 5% will be left bilateral. So the non-posterolateral cases or non-Bockler duct cases consist of a spectrum of diseases such as Morgagni-Lary, central hernia, eventeration, and hernia associated with pentology of Cantrell. So isolated cases comprises of 60% of the cases. If at all there are malformation, they are associated with hemodynamic and mechanical consequences of the CDH. And complex cases can either be a syndromic case or cases which are not attributable to a recognized syndrome. So they don't have a recognizable syndromic phenotype. The risk factors are maternal age more than 35 years, pregestational hypertension, but not preeclampsia is associated with increased risk of fetus developing CDH. Conversely, maternal black ethnicity is considered to be protective factor. Chromosomal abnormalities such as trisomy 18 has 2 to 5% association with incidence of CDH, and others like trisomy 21, 9, 16, 22, and other copy number variations like tetrasomy 12p, and so many other deletion and duplications are there. Associated non-chromosomal syndromes like Frenz, Pallister, Killian, Cornelia de Lange's, Matthew Wood, spondylocostal dysostosis are there. And pathophysiology is the main problem of CDH is not the defect itself, but rather the occurrence and degree of the pulmonary damage. So what happens is the CDH will cause herniation of abdominal contents of the thoracic cavity. They will impair the lung development, which in turn causes severe alveolar hypoplasia. That will cause abnormal pulmonary vasculature that leads to hyperreactivity, which in turn causes pulmonary hypertension and persistence of fetal circulation, which will cause the hypoxia, hypercapnia, and acidosis sequence in the fetus and increased mortality and morbidity. So the standard guidelines formed by these societies says, except for the American Institute of Ultrasound Medicine, all the other societies says that visualization of intact diaphragm on both sides is comes under the standard view. So prenatal diagnosis of left CDH can be made in 80% of the cases in left-sided and 60% of the case in the right-sided CDH. So the diagnosis is always by indirect signs. So which shows herniated viscera with or without liver in the fetal thorax, and abnormal position of the stomach and mediastinal shift in the axial view of the lower thorax 4-chamber view. So the direct sign is like visualization of the diaphragmatic defect and herniation of viscera in the sagittal section. Color Doppler showing upturning of superior mesenteric artery is also an indirect sign of CDH. It is a valuable sign because superior mesenteric artery usually have the caudal course to supply the intestines. If it is upturned, which means that CDH is happening. So diagnosis of right CDH is always, prenatal diagnosis of right CDH is challenging, but the hints are like extreme leftward rotation of the heart, abnormal increase in cardiac axis, heart squeeze to the left lateral wall, upward displacement of the right hepatic lobe, but it is difficult to differentiate the echogenicity of the liver and lung. So color Doppler will help in identifying the suprahepatic veins the intrathoracic region. So ERNICA, the European Reference Network on Rare Inherited and Congenital Anomalies, they have proposed a standardized prenatal ultrasound features on right congenital hernia, diaphragmatic hernia, in which sagittal section should show the herniation of the liver and visualization of the hepatic vessels above the diaphragm, and anechoic Doppler negative gallbladder inside the liver in the herniated liver, and bowing of the umbilical segment of the portal vein towards the left side. These are the signs that can hinge towards the diagnosis of right-sided CDH. So the fetal umbilical vein deviation in congenital diaphragmatic hernia proposed by Douglas H. research, what he is telling is umbilical vein ratio can be used to tell the accuracy of liver herniation. So he concluded by telling that 93% of the right-sided CDH and 98% of the left-sided lesions have an umbilical vein ratio outside the normal range. So a ratio of less than 0.4 is predictive of liver herniation. So this is the axial section of the liver showing the mid-hepatic portion of the umbilical vein. So we have to measure the distance between the outer border of the mid-hepatic portion of the umbilical vein to the inner margin of the rib on either side, and the measurement is taken and the ratio is measured. For example, in this case, it was 0.22, which is less than 0.4, and there was a liver herniation. So fetal MRI is a complementary tool to the ultrasound studies to better define the fetal anatomy. So it is powerful in case of atypical or complicated by multiple abnormalities. But we should keep in mind that MRI has limited benefit in early gestation. So the newer modalities like 3D reconstruction using MRI are used. They has been validated to visualize, locate, classify, and quantify the defects, and they are useful in prediction of patch placement and the ability to personalize the patch design based on the 3D printable templates. For example, this is the 3D reconstructed diaphragm, in which the red one is the intact diaphragm and the yellow is the defect part. So we can reconstruct the defective part so that we can plan for surgeries in future. So the differential diagnosis, left-sided CDH is an anechoic lesion, so it should be differentiated from macrocystic CFAM and unilateral thorax. To differentiate macrocystic CFAM, usually left CDH will have stomach as a content and superior mesenteric artery course can be seen, and unilateral hydrothorax is an anechoic crescent-shaped structure in which the lungs is within, and the lesion will be usually peripheral. And right-sided CDH is an hyperechoic lesion. It should be differentiated from microcystic and pulmonary sequestration. Microcystic CFAM is the liver is weak echogenic compared to the bright microcystic CFAM. Pulmonary sequestration, you can see the feeding artery to the lesion from the descending aorta. So prognostic indicators are like early gestational age, chromosomal anomalies, non-chromosomal syndrome, increased nuchal translucency has a poor outcome, pulmonary hypoplasia, pulmonary hypertension, mediastinal shift, high pulmonary artery resistance, intrathoracic position of the liver, LHR, O by LHR are used as the prognostic indicators. So the method for calculating LHR is like you have to multiply two orthogonal diameters of the contralateral lung to the diaphragmatic defect, which is located between the ribcage and the heart by the head circumference. This measurement can be done in three ways. One is the longest lung diameter and the longest perpendicular diameter as done in this case. And the other one is AP diameter of the midclavicular line, and the perpendicular diameter midpoint of the AP can be taken. Other one is manual tracing. Manual tracing is always usually reproducible. So the interpretation of the result is if the LHR is less than 1, it points towards poor prognosis. If it is 1 to 1.4, ECMO is needed and 61% of the survival if the ECMO support is given properly. More than 1.4 has good survival, 100% survival. O by A, LHR 45 and above has got good survival. Less than 45 has poor prognosis. Less than 25 severe CDH. So the survival with liver up position will be 10%, with liver down will be 25%. Less than 15% with liver up has 100% mortality. And QLI is quality of lung index. If it is more than 1, it is good prognosis. If it is less than 0.6, it has got poor prognosis. So how valid is this O by E LHR? So a multicentric study was done including 122 patients who has proved that the first measured O by E LHR per patient significantly predicts the survival and development of chronic lung disease in survivors in isolated left CDH. So O by E LHR first predicts the good survival and long-term prognosis of this patient. So antenatal management should focus on ruling out the structural anomalies by doing a proper TIFA and a fetal echocardiogram to rule out the intracardiac anomalies, fetal MRI if required, amniocentesis to rule out chromosomal and genetic abnormalities, serial monitoring of fetal growth and lung development by measuring the O by E LHR every 2 weeks, pediatric surgeon counseling and multidisciplinary team formation is important. If less than 24 weeks and moderate to severe lung hypoplasia is observed, option of termination of pregnancy is offered if the couple is desiring that. So prenatal management, like the prenatal aim is to stimulate the growth and aid in the development of the lungs before birth by preventing the fluid from escaping the lungs, because the fluid in the lungs are going to produce the pneumocytes, which are going to produce the surfactants. Our aim is to increase the chance of survival, but we should make sure and we should explain the patient that it is not the definitive surgery of the defect. So there are two techniques using the fetoscopic method. One is the plug technique, in which a foam plug or a titanium plug is kept in the trachea, and it can be unplugged using the exit technique. It has a higher survival rate of 75%. And the other one is fetoscopic endotracheal occlusion, which is the FETO. The fetal selection should be an isolated case of CDH, not associated with any chromosomal or genetic abnormalities, no associated structural anomalies. It should be a moderate to severe pulmonary hypoplasia. And the timing is usually for severe CDH 27 to 29 weeks and moderate CDH 30 to 32 weeks. The anesthesia given is epidural or loco-regional. Prognostic factors includes the lung size, that is the O by E, LHR, and liver position and the site of the defect. Fetal MRI, this study, 2018, the study released by them, they have told that they don't use the fetal MRI for decision making for fetal procedure. Free of medication, toccolysis and antibiotics can be given for 24 hours. So the procedure duration is usually minimum 10 minutes. The mother in the supine position and with lateral tilt. Direct access of the fetal mouth should be aimed. Pancuronium, atropine, and fentanyl is given for muscle relaxant and pain relief, and to prevent fetal bradycardia, atropine is given. Skin incision is made with and disposable flexible 10 French cannula is inserted along with the trocar. Fetoscope of 1.3 mm fiber endoscopic is inserted, and we flush the fetus with crystal oil to improve the vision. So the landmarks is like tip of the nose, philtrum, tongue, raphe of the palate, uvula, epiglottis, and ultimately the vocal cords. So position between the cords and the carina, the balloon is inflated with 0.6 ml of isotonic saline. Once inflated, the balloon is detached. So excessive amount, whatever, because of the irrigation is there, it should be removed off. So this is the technique. You can see the fetus in the favorable position, and the trocar is inserted and fetoscope is inserted, and the balloon is inflated, and fetoscope is removed. So total trial is a tracheal occlusion of to accelerate the lung trial, which is a clinical trial. So CDH with severe pulmonary hypoplasia, 5 participants were taken, and FETO was done at 27 to 29 weeks, and planned balloon removal was done at 34 weeks. The mean interval between the balloon insertion and the removal was 34 days, varying between 24 to 39 days, and 47% of the patient went in for preterm labor, but it showed high survival rate. In the case of severe pulmonary hypoplasia, there was a high survival rate of 40% compared to 15% expectant management. So this is the exit technique. The basic principle of the exit technique is to maintain the utroplasmal circulation with neonatal anesthesia by controlled uterine hypotonia. So the exit procedure allows the pediatric otolaryngologist, pediatric surgeon, to provide airway patency of newborn during the delivery. So if at all not diagnosed in antenatal period, postnatally it can be diagnosed by presence of scaphoid abdomen, diminished breath sounds in the ipsilateral side, and displacement of the heart to the contralateral side. Chest X-ray shows bowel gas above the diaphragm accompanied by mediastinal shift. So the prenatal management, according to Congenital Diaphragmatic Hernia Euro Consortium Consensus 2015 update, OBE LHR should be measured, and position of the liver should be always mentioned in the case. And prior to 34 weeks means steroids should be given. 39 weeks above, and high volume center delivery should be there, and multidisciplinary team should be involved. So delivery room management, as a part of obstetricians, we should know that the baby should be intubated routinely without bag and mask ventilation, and the goal of treatment is preductal saturation should be maintained at 80 to 95%. That is called the sign of honeymoon. That is preductal saturation more than 90 should be maintained, and peak pressure should be as low as 25, and nasogastric tube should be inserted. Normotension should be maintained. Inotrophic vasopressors, if at all the hypertension is not corrected, pre-medication neuromuscular blocking agent should be given. So ECMO is extracorporeal membrane oxygenation in congenital diaphragmatic hernia. The indication is failed conventional ventilation and vasoactive medication and persistent pulmonary hypertension. So the aim here is to reduce the stress, acidosis, and severe hypoxemia. Hence, the crisis of persistent pulmonary hypertension can be reduced. So the mode of action is temporary mechanical support that will remove the carbon dioxide, oxygenate the baby, and provide hemodynamic support to the baby. If the preductal saturation, I mentioned that the honeymoon sign is more than 90. If it is less than 85, that it indicates poor prognosis, and arterial PCO2 more than 100 is a poor prognosis. So the early initiation of ECMO less than 4 hours should be initiated if the poor prognostic factors are present, and it has showed an improved survival rate of 63 to 70% in the modern era. So postnatal surgical options are like patch closures by Goretech, which is the prosthetic patch, and Surgis is the bioptic patch. Survival rate is around. This is a 15 years study in a single institution. They have classified the era into 1, 2, 3, 4. In our era, we use this inotropes, vasopressors, ECMO, prostaglandins, milrinone, everything. So they are telling that the survival rate has significantly improved from 38 to 58% to 72%. The long-term sequelae are like cortical or basal ganglia damage, growth retardation, GERD, chronic lung disease, oxygen requirement, failure to thrive, perioperative complications. So take-home messages: CDHs are rare. Once a high mortality, that is 50 to 70% once disease, which dramatically improved the survival rate with improved strategy in the treatment over the past 30 years. Prenatal detection of CDH and prognosticating with the OBE LHR aids counseling and planning of safe delivery involving multidisciplinary team. So pulmonary hypoplasia and pulmonary hypertension determine the survival rate. So prenatal surgical interventions in severe lung hypoplasia has improved the survival rate to from 0 to 30 to 50%. Intervention of ECMO in the management of CDH in postnatal period has improved the neonatal mortality rate. So CDH International is a global organization which helps the people who have congenital diaphragmatic hernia, and they are celebrating global awareness for CDH in every year in April 19. So it was started in 1993. So if at all patients need any help, they are ready to fund the people who are suffering from CDH. Thank you for listening.
Thank you, Dr.
Thank you, Revati. I think that was a very presentation, although with a lot of food for thought, and I think we have a lot of points for discussion which our seniors will just take on. There is a mandatory trade presentation to be done. So Vishal, if you could just start the trade presentation. After that, we'll take on the discussion with our experts. Thank you for being with us. And we are back now with a host of questions that the audience also has put up for our experts. I would like to start with any comments that you have to make based on the presentation so far, and then we'll take the questions. So Mohit sir, Taylor Praveen sir, Leela Kumar sir, all yours.
Absolutely brilliant. Both the presentations were brilliant and comprehensively covered the package right from the embryology to the management. So I think they would have answered most of the questions. I haven't seen the questions yet, but I think they were self-explanatory. Let's take those questions one by one.
Sure. Praveen sir?
Yeah, I think I'm really proud of them in the sense they've really done great. In the sense, I mean, they have really comprehensively put everything together. And I think once you hear them talking like this, and then when you hear them, I think it is like a revision. I mean, you have gone through everything. So I really congratulate them. And I think we need to it's my suggestion in the sense, it was very fastly taken through in the sense, I think it would have been much more better because quite a few times I missed. I could not comprehend, maybe because of my age, I don't know, but then still it was too much to me to assimilate. But anything, because the information was so much that I think they need to take it through because the time given is short.
Yeah.
Anyway, wonderful. I think, as Mohit said, most of the questions might have been answered by their presentations. And if there are some more,
still there are a few.
Yeah,
yes,
definitely. We will go through it.
Leela Kumar sir? So you need to unmute yourself, please.
Thank you, madam, for involving me in this kind of discussion. Navya and Revati, I think they have really presented very well.
Thank you, sir. And in fact, thank you for treating all our patients who come with this. But there are some questions that have come up here, and I think we would like to take them one by one. So the first question is, how frequently should we be taking the LHR ratio? Dr. Harshiba Kaur has asked.
The LHR, if you want to prognosticate, you got to take it in every case that you do. And once you have, beyond 16 weeks, you take the LHR, but now we know that we have to take the observed to expected LHR more than the LHR because that's more accurate and less gestational age dependent. And every time the patient comes for a follow-up, you prognosticate based on the LHR or the observed to expected LHR. If it is worsening, you know it is worsening. If it's status quo, if it is improving, you know it is improving. But you
So
cannot
basically, it will change.
Yeah.
Basically, it can change because especially in some contents like sliding hernias, sometimes you actually might get things to be better also.
Yeah.
So it is a good idea to do it at every visit is what you're saying.
It's mandatory, yes.
See, basically, when we, the major problem with this congenital diaphragmatic hernia or eventeration is that there is a possibility of lung hypoplasia. So basically, when you want to know how much of normal lung tissue which is available, unless you evaluate either through LHR, more than LHR, OE-LHR is absolutely specific. And unless you evaluate every visit, I mean, you may not be able to prognosticate them properly. Of course, we do depend upon hydrops, you do depend upon polyhydramnias, associated abnormalities, gestational age where it has appeared. But still, this is one factor which to greater extent tells us about the hypoplasia of the lung.
Sure, sir. So thank you. That is a very clear message from our experts that we should do the LHR in every visit that we have. There's an interesting question, actually, I think Leela sir and all can answer. Can this surgery, I'm sure the surgery is about eventeration. So can this surgery be done via laser antenatally? Is there a role of doing antenatal correction of eventeration of diaphragm?
Well, the only surgery option available is a FETO.
I think what we need to understand is in the FETO also, sir, we are not actually correcting the diaphragm. So we are not.
That's what I'm coming to. So even the Texas hospital, that is the premier hospital for fetal surgery, is also only on open spina bifidas. You don't correct diaphragmatic hernias or diaphragmatic pathologies prenatally. And laser is something which is not used at all for that type of correction. So the only surgical, I would say, it's not even surgical, but the only option available is FETO, the tube. So you cannot actually correct diaphragm prenatally.
Whichever, even by Leela's, Dr. Leela's opinion also as a surgeon.
Yeah, sorry. Yeah, he is the right authority to answer this. Sorry, sir.
So sorry for the interruption, sir. But I think there is nothing like laser. The latest development that is there in the correction of diaphragmatic hernias is a thoracoscopy. Yeah, we have been doing thoracoscopy in those patients who are quite stable and then a good weight child. See, definitely the morbidity has come down with thoracoscopy as compared to an open surgery. So the latest in thing now is doing it through a laparoscope that is called as thoracoscopy. So I don't think there is anything like laser.
But you're talking about postnatal, yes, sir. But you're talking about postnatal surgery, and there is no role of antenatal surgery here. Madam. The antenatal FETO that is done only as a tracheal occlusion to maintain the lung volume, so that despite the compression, the lung volume is maintained.
Even regarding that, madam, there has been a lot of discussion and thought going as to how much is the validity of all these procedures that have been done antenatally, keeping in view the complication rates and the prognosis also. So even in there is a lot of thought process in the larger centers where they have been doing an antenatal interventions. So now most of the centers have given up antenatal intervention, and they've tried to say that probably postnatal intervention is always much better than an antenatal intervention, keeping the prognosis in view.
I think the jury is still out on that, sir, because the studies are going on, and there is some role even when we occlude the trachea and let the lung remain in its volume. There are some cytokines and some cellular growth factors which help in the further development of the lung. So there are many theories going on, but like you rightly said, there is a lot of thought going on there. This question is definitely for you, sir. What was the reason for your early surgery in the eventeration case on day 3?
Madam, one thing is for sure that both eventeration and diaphragmatic hernias are a medical emergency. They're never a surgical emergency. Surgeon is called for operating on this baby only when they are medically fit. So it all depends if the child is fit medically immediately after delivery or after the child is born, probably there is no point in waiting further. So the earlier you operate, the earlier the recovery of the child. Suppose the child is not medically fit and needs to be medically managed for the fitness, probably that is where we take some more time in operating these children. But if they are fit, I don't think there is any role for waiting for any duration before we take on surgery.
Thank you, sir. Thank
Eventeration
you.
babies, the eventeration babies are generally as enumerated. They are much stable than the diaphragmatic hernia, so they are offered early surgery.
Thank you, sir. So that clarity is very like comprehensive there. That
Sure.
anyway we have to do surgery, so we might as well do early. Yes, sir.
What is the type of surgery that you contemplate for an eventeration?
So again, from how you approach. Suppose you are approaching through the thorax, through a thoracoscopy, it is plication through the thorax. Even if you are approaching through a laparotomy, it is plication. The diaphragm is reefed. See, the diaphragm is weak, sir, in eventeration. So the diaphragm is reefed up to make it much tenser than anything else.
Okay. Thank you.
Do you ever need to redo a eventation surgery, sir?
Yeah, absolutely. That's a very valid question. See, there are instances where the reefed up diaphragm, see, though the diaphragm is reefed up, it is never a normal looking diaphragm. See, it is like just a barrier. The normal functioning diaphragm is never achieved even with plication in an eventation. Actually, in diaphragmatic hernia, the muscles are well developed. Once you close the diaphragm, probably it acts as a normal diaphragm. But in eventation, always the diaphragm does not regain its normal anatomical structure. It is only a membrane that separates the lung and the abdominal cavity. So it's a tight defect which is there between the thorax and the abdomen. And the normal functioning of it can never be achieved in eventerations.
It's just like a hernia, Rafi.
Yes, sir. Yes, sir. Absolutely.
Excellent. Thank you, sir. So there's another question by Dr. Chelapan, and I think Dr. Rakesh Patel has asked the same thing. At what gestational age do we expect to see the upturning of the superior mesenteric artery in cases of CDH?
Whenever there is a mesenteric pulse, whether it is 12 weeks or 15 weeks, it doesn't matter. I mean, whenever there is a pull, you put the color Doppler on. If there is an upturn, it is upturn. It's the gestation. It's not gestation age based.
It's based on the pathology, because the pulling of the mesentery is what causes that. And thank you, sir.
You can actually pick it up in the 11 to 4 week scan too. If you have picked it up there,
So there's another one. What is the best view to see the diaphragm? Praveen sir, would you like to comment on this? Coronal or mid-sagittal?
I would have both.
It's actually a dynamic thing, I would think.
Yes, yes. And not only that, I mean, see, there are certain situations, it all depends on the maternal BMI, it all depends on the amount of amniotic fluid, it depends upon the gestation age of the fetus, position of the fetus. There are so many factors which are responsible. So it depends on in which position you are in order to evaluate. See, the basic concept is this, that if you can first and foremost then try to identify the normal side diaphragm and try to trace it towards the opposite, that's how you achieve is what you need to do. In the sense, you can take a sagittal section or you can take a coronal. I would prefer to do a coronal section because there is a comparison. And not only that, another one point which I have been little convinced about is that there is a paradoxical moment in an eventeration. If you observe the fetal breathing movements, whenever there is an eventeration, it is usually the one diaphragm which is abnormal or weak. It moves in an opposite direction when the other diaphragm is moving the opposite way. That is, suppose the right side diaphragm is normal, left is eventeration. The right pulls down, pushes down, whereas the left goes up. So this sort of a paradoxical one, which really helped me to differentiate some of the cases where, I mean, of course, eventeration, as you all know, is very, very rare. And there are very subtle features. As Navya has presented, it was a wonderful case where left-sided diaphragmatic hernia, stomach being in the normal side, the left lobe of the liver is the one which has gone up. So that is one of the typical features which they describe. And the amount of diaphragmatic shift, mediastinal shift is also not as much as you expect in a congenital diaphragmatic hernia. So these are the subtle features which will come. So basically, if you get back to the basic question is, that is the coronal view, which I would like to use, and also use the real-time evaluation where I would like to see the fetal breathing movements.
And as Dr. Mohit also said rightly, that if necessary, we can use a high frequency transducer to get better resolution of the diaphragm. But I think one of the most important things, sir, I don't know if you'd agree, is to chart the diaphragm in every case of a TIFA scan, which now I think has become part of the ISWOG guideline also, that we must comment on the diaphragm even if there is no mediastinal shift, because if you saw the embryology, the diaphragmatic defect has started way back at 4 to 5 weeks of pregnancy, and thereafter, the manifestation sometimes occurs later. So whether or not there is a mediastinal shift, I think it's a good idea to chart the diaphragm in every case of anomaly scan.
And it also gives us a legal protection, because tomorrow, if you have already charted down, and in the postnatal period, suppose you find a diaphragmatic hernia also, I mean, that is always a possible, because postnatally also sometimes they manifest. So if you have charted during the antenatal period, I think it is much more safer for us legally.
So in fact, one image where we show the heart and the stomach on either side of the diaphragm, that I think has to be documented, because we know that the hernias can suddenly come up just delivery. So documented one image which shows the heart and the stomach on either side with the diaphragm in a coronal section, I think that is, as Praveen sir rightly said, legally quite safe practice to practice.
So which again brings us to the point that there might be a diaphragmatic defect, but even if we have charted the domes, there might still be a defect. What we are documenting here is that there is no movement of organs, there is no herniation.
Herniation is not
so
there.
Because when we diagnose diaphragmatic hernia, we don't diagnose the diaphragmatic defect.
Yes, yes.
Madam, one point here that I would like to add is, we have of late seen late diaphragmatic hernias. Most of the time in the TIFA, the diaphragm is pretty well developed and there's no diaphragmatic defect. We have seen patients coming at 32 weeks diagnosed as diaphragmatic hernias. So there is an event called as late diaphragmatic hernias that are occurring. So that also should be kept in mind if we are documenting in the TIFA. Most of the time, these are documented during TIFA around 20-22 weeks. If there aren't diaphragmatic hernias, we just cannot say that we wouldn't getting a diaphragmatic hernia in the late pregnancy also.
Yeah. So actually, that's actually the problem is, the defect is there. As Chinmay has said, it is right from 4 weeks or 5 weeks. But the herniation is the one which on ultrasound we diagnose.
Absolutely.
So the herniation always depends upon the intra-abdominal pressures. Whenever there is an increased intra-abdominal pressure, then only the herniation takes place, which may not happen at the time when we are doing the TIFA. So sometimes it can increase as the gestational age progresses. In that situation, there can be diaphragmatic hernia late, and then it's one of the late evolving abnormality.
So that brings us to Dr. Chelapan's request here, that can someone please give precise take-home message for counseling patients with antenatal diagnosed CDH? So I think even if you don't diagnose a CDH, the counseling should be there, that there can be a late presentation. Because evolving anomalies is something we have to finish our TIFA scan counseling with. That there might be problems later on, because we don't see them because they have not manifested so far. I think Dr. Praveen, I think you will be the best person to tell us precise counseling points for antenatally diagnosed CDH.
So basically, whenever we diagnose a congenital diaphragmatic hernia, we would like to prognosticate it. Prognostication basically is based on the LHR, one factor. This other one is the OE-LHR, which is much more specific than the LHR. Presence of polyhydramnios, presence of hydrops, amount of mediastinal shift that is taking place. And another thing which Vivek has postulated recently is the cardiohepatic angle, which will tell us whether there is a liver up or not. And liver up is again a feature which is a bad prognosticator. So keeping all these factors taking into consideration, gestational age at which the diaphragmatic hernia has appeared, you need to counsel them saying that based on the OE-LHR and presence of the liver up sign, the prognostication, if it is not there, prognostication is good. And if it is there, the prognostication is bad. And OE-LHR, anything less than 45% is definitely bad prognosticator, and it is definitely going to associated with hydrops as well as polyhydramnias. So counseling basically is that if suppose you have a fetus or a mother who has a previous case of congenital diaphragmatic hernia who comes back and for a counseling where you don't find it, still it is better to tell them that there is always a possibility that there can be a late occurrence of diaphragmatic hernia. So this is I think most of the factors which have to be got to the couple's mind is what has to be importantly counsel them, and then tell them about the feasibility of surgical, because now the surgeons have become wonderful. That is, the pediatric surgeons are doing a great job as far as the congenital diaphragmatic hernias are concerned. We have plenty of children who had diaphragmatic hernias antenatally detected who are doing extremely well. I think that is one important factor that we need to encourage these mothers to continue the pregnancy and get the surgical corrections done.
Thank you, sir. And
you could also use the pulmonary artery index here at times as to, sort of predict the pulmonary hypertension in these cases. When you look at the pulmonary artery, they normally have to have a good diastolic flow. So if you have a decreased diastolic flow or an absent diastolic flow, it means that these babies are going to have pulmonary hypertension. That's also one of the, of course, poor outcome predictors that you can use in these cases.
There's one question by Dr. Nisha. Antenatally, there's a role of stem cell therapy.
You should tell.
I don't think there's any research done on this in terms of this thing or any outcome. As of now, no, we don't have a
clear idea
or anything to say or offer that way. That is not one of the indications to offer stem cell therapy here. So can you please let us know if any consultants have done FETO or have any experience regarding FETO? I don't think we have done FETO here in our country so far. The availability of the balloon itself is one of the limiting factors, and it's a very, very sort of specialized procedure. I have had the opportunity to see FETO procedures done in King's College, London, and I've heard of other centers in Europe where they do it. So it's not, we have seen videos, and I think Revati presented the pictures of how that is done. The main thing is the selection of patients for a FETO procedure, and only patients who are at a risk of moderate to severe lung hypoplasia are selected, because the ones with mild lung hypoplasia will do good anyway with postnatal surgery. And the whole purpose is to occlude the trachea so that even when there's a compression by the herniated bowel, the lung volume is maintained, and that as I said, the local cellular growth factors are there, and the total trial that has been done that has shown that it has a good impact. But like Leela Kumar sir said, there are also thoughts about long-term effects of this kind of a tracheal occlusion antenatally, which can sometimes lead to tracheomalacia and other problems. And therefore, the overall, like in any fetal procedure, you have to have a very, very comprehensive judgment of the risk and benefit of the process. In India, what has been done in some centers, what I know is you can liaise with centers abroad which do the FETO, and if your patient can travel, then she can go to those centers. You can talk to the consultants there, get the FETO organized, and then she can come back with the occlusion. The second part of the surgery is the removal of the balloon, and that need not always be done fetoscopically, because that is also possible by doing a percutaneous puncture of that balloon by under ultrasound guidance. So some of the centers have tried doing both, because otherwise you need to either remove it fetoscopically or immediately at the time of birth, which can sometimes be very dangerous and has been fatal in a few cases. So the experience is still a bit patchy. We are hoping over a period of time, once we get more evidence about the FETO and the facilities in India, it should be available. As of now, we calculate the ONE LHR and send to Dr. Leela Kumar, and he does the rest of the counseling. And this particular patient, of course, terminated, but we did have many cases of successful repairs. They were done earlier, so Revati presented the one which we have seen. Sir, would you like to take this one? What is the role of Magoons index for prognostication? I think we're just talking about the pulmonary artery. Leela Kumar sir, do you rely on the Magoons index for prognostication?
Generally, no, ma'am. See, our role comes in good prenatal counseling, madam. And then prenatal counseling is generally based on the risk assessment. See, all the factors that you give us and all the inputs that you give us, as you said, the head-lung ratio, OE head-lung ratio, no high drops, no polyhydramnias, gestational age, and the side of the defect definitely has a bearing. And as discussed previously, even the contents, whether it's a solid organ, stomach, which carries poor prognosis, as compared to simple intestinal herniation. So based on this, we make a risk assessment and then prognosticate and then counsel these patients. See, risk, apart from this, the most important aspect also that has to be told is an institutional kind of delivery. Whenever you are counseling all these patients, institutional delivery is a must for a good prognosis in all diaphragmatic defect patients. And finally, an unbiased opinion. I think you should not try to take the onus on yourself. It should be an unbiased opinion that should be given to the parents, and the choice is always given to the parent based on the risk factors.
Thank you, sir.
I think the
So-
Magoon index is also difficult to reproduce every time. Yeah,
Quite,
it's not very technically easy to take. You can
We have a
theoretically say that
modified Magoon nowadays,
yeah.
I think they do.
And the margin is not much between a favorable from high mortality. So if you have 1.7 and more, you say it's favorable. 1.3 and less, it's a high mortality. So you have to be very accurate how you measure the arteries, and therefore I feel it's not so reproducible.
True, very true. So CDH left-sided with poly with OA 35%, 22 weeks prognosis and frequency of monitoring. Well, I think that's all being discussed here any which way, that you have to do that at every sitting. So at 22 weeks, whether you want to. So let me just ask this question, sir. Praveen sir, would you do amniocentesis for chromosomal analysis in every case of CDH? Would you suggest?
Theoretically, yes. I mean, theoretically, you need to do. I mean, even for an eventeration also, they are associated with the Beckford-Friedman or a trisomy 21, 13, 18. But in practice, I don't think we normally do. If it is an isolated congenital diaphragmatic hernia, particularly the left-sided diaphragmatic hernia, I don't advocate that every patient should get a chromosomal microarray. But then, in my report, I would
exactly. It's not harmful to just suggest it.
Suggest, yes, we do suggest, because I mean it is to safeguard ourselves.
Yeah, because there's no harm. See, even with minor markers, when we look for these aneuploidies,
Yes,
when we have a major defect, especially one where you're looking for surgical correction, it is a good idea to. Leela Kumar sir, have you had any experience where, you know, the antenatally it has been followed up for surgery, but you found other problems and therefore diaphragmatic hernia has not been managed? I mean, you didn't have to do the surgery because the baby was otherwise abnormal.
Generally, no, madam. See, most of with the antenatal ultrasounds, I think most of the major anomalies can be antenatally picked up, discussed with the parents, and then whether to carry forward the pregnancy or not can be decided in the prenatal period only.
You've never had isolated Down syndrome. I mean, isolated diaphragmatic hernia as a presentation of Down syndrome or anything like that.
Generally, no.
Generally, no.
No.
So that is
Theoretically,
true.
it may be possible, but I don't think those patients have really come up for surgery.
And more than Down syndrome, now that our knowledge of genetics is increasing and there is a possibility of detecting microdeletions and duplications,
Absolutely.
it's not harmful to, you know, kind of mention this to the parents. And if they want it, then we check it. There is a question on that also. Jay Desai is asked that for CDH, do we advise 350K or 750K or whole exome sequencing? I think 315K and 750K. Fetal microarrays are generally the 750K, which we do routinely, and whole exome, again, I don't know, sir, I'll take your advice. Would you do a whole exome for everyone?
No, I don't think so. Our patient will run away.
Yeah.
So apart from the cost, I think,
yeah.
Dr. Mohit, what
Even
I see?
single gene mutations can be picked up in 750K as well. I mean, how often do you see them? It's more about the trisomies that we are concerned about. Yes, we have X-linked disorders, unknown Fizz syndrome and all, but single gene can also be picked up in 750K, and that's what we prefer now. Everybody does 750Ks. That's a
So
better way.
we prefer doing a microarray because that's like a more definitive result, whatever we get.
Yes.
The whole exome can sometimes be tricky when you do in fetal whole exome empirically, because we might get variations of uncertain significance and in the presence of an anomaly that might become fatal for the patient any which way. So there is another question on, can fetal MRI in coronal and sagittal section differentiate and confirm eventeration versus hernia?
Well, MRI is supposed to be much more specific in identifying eventeration. Whereas a congenital diaphragmatic hernia, you don't need. The problem is that when you have a differential diagnosis of a congenital diaphragmatic hernia versus eventeration, that is when you definitely would like to get an MRI done. Right. But for that, I don't think. But then eventeration, yes, positively, I would definitely put in my report saying that I am suspecting an eventeration, but I would like to get it confirmed by doing an MRI. It's a safe bet.
It's a safe bet. That's exactly the point. So I think MRI, what we feel is it's not always because we can't see things, just like in corpus callosum or, Vermean problems. It's not like we are unable to see it, but somehow we feel it's better to be safer and, get a second modality.
Commitment.
You're putting the onus onto somebody else.
No, but I don't know, sir. Sometimes, like we may be digressing here from the main topic, but when it comes to those mild CNS anomaly, changes, it's safer to have another modality say that, well, it is a rotated vermis as compared to an hypoplasia. Bimal sir is very intently looking at this. Sir, any final words?
Theoretically, they have a lot of, even ratios in MRI that they want to calculate, but it also depends again on the availability of a skilled MRI person to interpret it in the right context.
That, of course, is the final word everywhere.
Yeah, that's what it is. Yeah, you have the lung volumes, you have the liver to thoracic ratios. In fact, they also measure the size of the defect, but on 3D MRIs. But then again, that is quite relative. But I agree with you that sometimes it always helps to lean on to other modality so as to be more assertive about your suspicions.
What is the role of gastrocardiac angle in CDH?
It's a beautiful paper
by Vivek.
Yeah, I mean, you measure it.
Yeah, it is basically if it is an acute angle, there is no left lobe herniation. If it is an obtuse angle, there is a left lobe herniation. It's as simple as that.
They have a cutoff.
Yeah, angle subtended between the stomach and the cardiac margin. If it is acute, there is no left lobe herniation. If it is an obtuse, when it becomes wider, then there is some angle also, 140 or 120. I don't remember exactly. Yeah.
So 54.5. Actually, as you rightly said, you draw a line along the medial aspect of stomach and heart, and that's what you see.
So I think where we have reached so far is that you are saying there is definitely a role of checking the diaphragm at every anomaly scan. And we can, if we look carefully, we can look for herniation of contents from abdomen to the thorax, and therefore diaphragmatic hernia is detectable. But it is possible that there is a defect, but there is no herniation at the anomaly scan. So it may also appear at the late gestation age. So what will save us there is if we have saved pictures of the thorax and the abdomen intact and the stomach down and heart up and everything in its own place in the mediastinum, that will help. Now, there is a question here from Dr. Tejas Taman who says, how will you counsel if at 20 weeks, the LHR O/E was 45, more than 45, but on follow-up, it has worsened. And say at 28 weeks, which is beyond the legal gestation age for termination. Now, the point is we counseled everything was good at 20 weeks, but by 28 weeks, things have worsened. So how will you take this counseling forward?
I mean, you need to tell the facts in the sense at 22 weeks, at that time, the prognostication was good. See, suppose, for example, let us say not only the OE-LHR, but suppose later on it develops hydrops, later on it develops polyhydramnias. It's nothing that, I mean, you can have, I mean, in the first counsel itself, you have to tell them that there can be a progression. There can be a static, I mean, it can be static, it can progress, or it can even regress also. So these are all the things that that can happen. So I think in the first counseling, when you've made out the diagnosis at 22 weeks, better to tell them that this is how the evolution can take place.
See, many of the youngsters will think when you tell them so many problems, they will probably not continue at all. But you know, there is that difference between the science and the art of your counseling, where you need to tell them all the facts, but then tell them in a way that, you know, you can take it to a logical conclusion. And especially now that you've raised this issue of beyond the legal gestational age for termination, the MTP law has got modified last year in a way that we are not completely helpless now. If there is a situation where the fetus has a gross anomaly, which either could not have been detected earlier, or for some reason has reached a stage where, you know, you cannot continue this pregnancy with a good outcome, you can opt for a legal opinion and get a permission for a late termination. And this has happened in cases of aneuploidies and other problems, even at 32 to 33 weeks of gestation. So let's not get very worried with this, you know, gestational age part of it. But like Sir said, the first counseling only, it should be very clear that these could be evolving problems, and hence the prognosis as it stands today at 20 weeks may not be the same, and things could get worse. Even sometimes everything might be okay, but because of polyhydramnios, she might set into preterm labor, or she might develop any other obstetric complications like preeclampsia, where you have to deliver the baby now prematurely, and hence your prognostic factors become really bad, because like Leela Kumar sir is not going to be happy if I tell him that at 32 weeks we delivered this baby. Because sir, what is your problem with delivering babies prematurely?
Absolutely, madam. See, we generally don't have that kind of general condition that is fit for surgery in preterm children. Preterm children generally have their own risk, like intraventricular hemorrhages are common, anesis are pretty common, and then generally the surgical risk definitely increases with prematurity. So we always prefer that the gestation should be continued till term unless warranted to deliver preterm. So that itself is a good important prognostic factor which determines the survivance.
So for some of the audience who might be thinking that if it can worsen, if the prognosis can worsen, why not deliver it earlier in 28 weeks when the prognosis is still okay? So the lesson is not to deliver early because you do not want a premature baby. Dr. Bimal Sani, you want to say something?
I wanted to ask a question to the esteemed panelists. Has anyone seen a defect without an herniation? Because I think a lot of us have been using looking at the diaphragm as a protocol, but because I've never seen one, maybe someone who's been able to pick up a defect in the diaphragm without a herniation.
But I think we have been discussing about the herniation only. We have not been discussing.
I don't think, sir, antenatally we'll see a defect, but Leela Kumar sir could answer that. So have you ever seen a case where there is a diaphragmatic hernia presenting postnatally? Because that would be the case which had a defect, did not have any antenatal manifestation, but then still had the defect.
Probably that may not be a congenital diaphragmatic defect, madam. See, we are seeing acquired defects wherein probably the diaphragm ruptures following trauma and all. But congenital diaphragmatic defects, I don't think there can be a defect without any herniation. And then they generally don't come up for surgeries also. When isolated the diaphragmatic defect for surgery, I don't think they do come up.
So if there is a defect and it does not herniate, probably it does not present postnatally also.
Yes, ma'am.
No, suppose, sir, do you see infants with congenital diaphragmatic hernias who were not antenatally diagnosed?
Absolutely.
Yeah.
Absolutely.
So, what was the cause for that sort of?
They're all congenital diaphragmatic hernias that have been missed.
Right.
Because most of them being asymptomatic. These are the patients who generally have no symptoms at birth, and then they are not institutional deliveries. Most of them are delivered at smaller centers, and they come for something else like respiratory distress in the infancy, where an X-ray chest is done, and then there's a pickup of diaphragm.
Yes.
No, my question was repeating that we need to document the diaphragm section in our TIFA and everything, but for the integrity of the diaphragm, it really doesn't help till the time we actually suspect a herniation. We are not going to pick up a defect without an herniation.
No. The idea of demonstrating the diaphragm or whatever it is in your TIFA is to say that everything is in place. It's
There's
not
no
that saying
herniation.
that that's it. No, it's not that there is a herniation. There's going to be a hernia. You can't predict it anyway. So the basic idea, and even the recent guidelines that have been postulated by the ICO also states that you have to document the diaphragm in the sense in the coronal section to show that the stomach is at the stomach, apex of the heart is at the apex. So it's not that we are.
Yeah, I was asking, has anyone actually been able to see a defect as such?
No.
Yeah, I remember one case, but it was not because of the diaphragmatic hernia. I think there was an ascites and then there was a rent in the diaphragm, but it was not a diaphragmatic hernia which was present. I could see there was ascites, and then later on, as I was following it up, suddenly I started seeing pleural effusion. So that is when I saw the defect, but then before that, no.
What is your opinion about the prognosis?
Your voice is not obvious. Yeah.
The earlier you diagnosis, you make a diagnosis, does the prognosis become worse?
Yes.
Of course.
So, suppose
Yes.
if we are diagnosing at 16 weeks, and that is also one factor we should take in counseling when
Yes.
Yeah, I think that was brought upon by the speaker for diaphragmatic hernia.
Yes.
And there is a question later on that sliding hernias can present postnatally, may not be detected antenatally. So like Leela sir was saying, they get missed. Many of the times they don't get missed because somebody is not scanned well. Many of the times they get missed because the defect is not so, the herniation is not so apparent. So that is the reason what Praveen sir is saying, that document the mediastinum, document a picture of the mediastinum, document a picture of intra-abdominal organs, because those sliding hernias which get missed other ones. In fact, we have one where it was a doctor and we had a sliding of the small bowel up and down. During the scan only we saw nothing, and then again we saw the hernia, and then again nothing. So within a period of 45 minutes, there was a changing picture through and through. So it may happen that the time that you have scanned, at that time, there was no distortion of the organs, and hence you did not see it. Whereas later on it comes. That's a very possible thing in sliding hernias. So the gestational age will matter because the earlier you see it, the earlier the pressure on the lungs has started. So if the pressure has started earlier, the prognosis is definitely going to be worse. Yeah. Whereas if it is,
of the lung
yes,
yes.
Or if it is present later, then the prognosis is going to be better. So Praveen sir, Dr. Meghna wants you to please tell about the angles between stomach and cardiac margins in detail.
I think we have already discussed it. That is the medial margin of the cardiac and the medial margin of the stomach. The angle is subtended. And whenever it is acute, it is normally said that there is no left lobe herniation. But whenever there is an obtuse angle between the stomach and the heart, then it becomes that the left lobe of the liver has herniated up. It is basically to say that the left lobe has herniated up. That is what is more important, because as we know that liver up sign is one of the bad prognosticating features.
Yeah, now there is
the question.
I think so, sir. If the question is answered, Dr. Meghna, you can acknowledge it. If you want some more details, sir is happy to give.
Say thank you, sir.
Thank you, sir, on behalf of everyone. So, Dr. Tejas has given a very thought-provoking question here to Dr. Leela Kumar. As Dr. Leela Kumar said, even after surgical correction, the diaphragm is not going to be functioning absolutely normal. So are we giving false hopes to the patients considering the socio-economic factors in Indian setup, which are completely different from the Western world?
No, madam. See, the purpose of operating these babies are because there is associated mediastinal shift, and also the lung compression because of the eventation. Generally, I was talking about eventation. It was not about diaphragmatic hernia. See, in eventation, what we are trying to do is we're trying to bring the diaphragm down so that allowing the lung to have some space and to expand. Even in the diaphragmatic hernias or eventation, the lung gets compressed. Whether the viscera go into the chest or not depends on kind of defect it is. But in eventation, generally the viscera don't go into the thoracic cavity. It is only the diaphragm that is pushed up. So in eventation, we try to bring the diaphragm down so that the mediastinal shift is corrected and the lung is given space to expand. See, that is the purpose of operating these babies with eventation of diaphragm. So I don't think we are doing much harm, but probably, as you said, we are not doing a great job in getting the diaphragm to become normal. Probably we are doing a job where we are trying to see that other things are much better than the diaphragm. The heart is given some mediastinal shift is corrected, and the lung is also given some space to expand.
I think that question is like the basic tenet of fetal medicine, because when we are talking of medicine as such, when we talk of adult medicine, we are talking of people who are not healthy. We are being treated to go back to society as healthy people. So these are fetuses who are otherwise having problems. If nothing is done to them, we'll probably lose them. So whether there is a justification in intervening and getting them to come to society is something which you have to answer at every level. What about fetal growth restriction? What about any other anomaly for that matter? So it's not about false hopes. I think that's a very very extrapolated way of putting it.
No,
hope is never false.
way of thinking. Pessimistic way of thinking.
Because what we are trying to say is there is a problem in the course of natural selection. These fetuses would either, lose their lives in the early newborn period, or lead very morbid lives, leading to a lot of distress to the families, and then going at a time when nobody is really prepared for it. So instead of that, we are trying in anything in fetal medicine. Otherwise, the whole purpose goes off. Then it's the same thing about renal problems. It's the same about cardiac problems. It's the same about everything. So it's not false hopes. It's about hope.
Yeah.
Whether they want that hope or not.
Yes. Chinmay, for Megana's question, I think I would suggest her to go through that paper published by Vivek Krishnan. It's a wonderful paper. It's a very simple one, simple concept, but then it's really useful in our practice. It is as a cardiogastric angle by Dr. Vivek Krishnan. It has been published in White Journal.
Yeah.
So, sir, my question is, medico-legally, where are we? We said we'll give a differential diagnosis for diaphragmatic hernia or eventation. If we cannot differentiate between these two, are we liable medico-legally?
I don't think so.
Leela Kumar, sir, would it make a big
Yeah.
difference to you if you don't know what's the diagnosis between eventation and herniation?
Yeah, I think we can put it this way. I would give a diagnosis of congenital diaphragmatic hernia and it turns out to be an eventation.
Yeah.
Are you going to be surprised, and is it going to create problems?
Generally, no. See, we generally don't take only the diaphragmatic defect as a risk factor. We also weigh it based on the other risk factors.
Other aspects.
Yes. So generally it doesn't make us bother us
Agreed.
much whether it is a diaphragmatic defect, which is a defect, or an eventation. Weighing other risk factors also taking into consideration. Probably that is where we need to consider whether it is going to be a good prognostic one or a bad prognostic. And
So
ultimately the patient,
mediastinal.
yes, ultimately the patient wants the prognosis, whether it's an eventation or a diaphragm, how my child is going to be. That is the basic question they want to be answered.
So your prognosis is mostly dependent on the distortion of the thoracic anatomy.
Absolutely. And as you said, other risk factors, weighing also the other risk factors.
So should we do DNA storage in case the patient opts for termination?
I don't know.
Yeah, but if you have already done a chromosomal microarray, why would you need a DNA storage?
No, suppose nothing has been done. I think the question means if there is a case of CDH and they're terminating, should we advise for DNA storage?
But the recurrence rate in cases of aneuploidy is very minuscule. I mean, if you're talking of syndromic, then yes, probably in that case, you could store a DNA, but that's because the recurrence rate is 25%. But for aneuploidies, it's hardly anything.
Yeah, I think if one is terminating and after terminating, one sees a lot of things like, overlapping fingers, blue sclera and things where you're suspecting
Yeah.
something like Trin
Yeah.
syndrome. Probably in those cases, a genetic
Those
workup
cases,
would be
Yeah.
reasonable. But if all other things are okay, then that's okay because they've terminated because they didn't want to have this condition and the recurrence risk is relatively
Yeah.
less. So I think we've had a very fruitful discussion overall. And the important take-home messages would be that look for the diaphragm in every anomaly scan. You may not see the defect per se, but if there is a herniation happening, you will see it. There is no way you will not see it if you have a good protocol of evaluating the thorax and the diaphragm in the anomaly scan. High frequency transducers can help get a better view of the diaphragm, as Dr. Mohit suggested. And if there is a if there is a herniation, then lung head ratio and the observed upon expected. Because just the lung head ratio is gestation dependent, whereas observed upon expected is gestation independent and more representative of the prognosis of the lungs. And tell them that, the prognosis can change over a period of time. And always involve the pediatric surgeon and the neonatologist in the. Sir, ECMO is something we had discussed. How important is ECMO in the perinatal management of diaphragmatic disorders? Suppose because every center might have an NICU, but they might not have ECMO. So is it essential that you should transfer a child to some place where the ECMO is available, or it's not?
Generally, no, ma'am. See, as you said that antenatally or prenatally, we have assessed the risk and though the child is in the high risk category and the parents want to continue the pregnancy, probably that is where probably we may have to think that the child might need an ECMO, and then counsel the parents accordingly, and then plan a delivery in a center where ECMO facility is available. Most of the time, generally, if the child has to go on ECMO, that itself says that it's a very high risk child, high risk baby, and then prenatally counseling should be done that these kind of baby are going to have problems. So I don't think you need to think about delivering babies where ECMO facilities are available.
Sir, in your experience, the ECMO babies, do they land up with developmental delays? I mean, literature does say that ECMO babies are more prone.
True, sir. Absolutely, sir. See, there are multiple problems with ECMOs. It is not that easy to say that we do an ECMO and the baby has recovered. So, and then ECMO has been new, and especially in neonatal period, the role of ECMO and then the long-term prognostication has definitely to be followed up, and then we need to have much more results and then views on having an ECMO in a CDH baby.
There is a lot of debate regarding this ECMO, in the sense there are people who are very firm about the usefulness of ECMO, because basically it is the pre-ductal saturation, and then I mean, how far, because there are some systematic reviews which have said that ECMO may not really improve the morbidity and mortality. So, I mean, it's very debatable.
Leela Kumar, sir, over the years with advent of fetal medicine, good antenatal scanning and so much prognostication, do you think you're doing more surgeries or less surgeries on congenital defects?
I would say the surgeries that we are doing are much better because we have counseled them antenatally in a proper way. See, previously patient used to have a lot of doubts when they come to a surgeon after delivery. Here we have been counseling them throughout their gestational period. They have developed some rapport with the fetal medicine people. They all know what they have to expect. And generally, most of the time, they are very receptive, and then they do understand the problem when the child is taken up for surgery. So more than the number of cases, I think patients are more receptive to surgery and its associated problem. Definitely antenatal counseling, and with the fetal medicine coming up in a big way, probably we are able to help the patients in a better way. There is no doubt about it.
Thank you for that.
May I ask for a pat?
No, sir. Most of the time, the pediatric surgeons say, because of you people, these patients get terminated, they don't even reach us.
No, no.
That is what I said. It should be an unbiased opinion. I think we should give an unbiased opinion as a clinician.
Thank you very much, sir.
Thank you.
So any words of wisdom from Vimal sir and Praveen sir?
Vimal sir. Vimal sir has been very quiet.
No, we can't hear you, sir. We can't hear you.
There's something wrong with you, Vimal. The audio.
Can you hear me now?
Now,
Yes.
now you're good. You're good.
Yeah. Kudos to Telangana. They're coming one after another with great meetings. Your last meeting, I of course, all the efforts were taken by you, but I took a lot of credit for that because I was flooded with messages coming from so many members across India for that meeting on FACE. And I said, no problem, let me accept those, no issues about that. And even today, it's good that you're picking up one niche subject and taking it up so beautifully, and great contributions from your young speakers, and then the seniors, Dr. Leela Kumar, Praveen sir, Mohit, have really put in. And as long as people go out with the right message, which they can put it into practice from tomorrow. See, that's the most important thing. Everybody who is joining in is looking for that can I get some points which I can put into practice next day morning? And I think your meetings are doing that. So thank you very much, Chinmay, for taking this forward in this way. So Telangana is going great guns.
Absolutely.
Thank you, sir. So
Thank you.
yeah, Praveen sir is there to kind of, whenever I tell me, say, I'll be there. No, the third Wednesday is really becoming pious for all of us. So thank you very much for this. And I would request all other members also to please, participate and send us cases which they want to present so that we can take up new subjects and new speakers every time. So with that, I think we come to the conclusion of today's program. I would want Dr. Vidya Sudha to give a vote of thanks formally, because it's very important to thank everybody who made this possible.
Thank you, ma'am. I would like to thank Ashok Khurana sir, Trialan Praveen sir, Chinmay ma'am, Vimal Sahani sir, Leela Kumar sir, Dr. Mohit sir, in their continuous efforts in updating these academic sessions. And also I would like to thank Dr. Revati, Dr. Navya, today's speakers, and also all the delegates for joining with us in this webinar. I would like to thank Vishal Mittal, Mr. Vishal Mittal, for this logistic support, and the trade partners, and all the senior members, which I did not take their names. Thank you.
Thank you, Sudha. And we can't thank the backend support by Vishal and Conferences International enough, because it's always so easy to get things organized with such highly efficient logistic support that we get from them. And overall, the central SFF team, I mean, we are really, really grateful for all the support that we always get. Having the ex-president, president, and president-elect present for a small program like ours, I mean, we are really humbled.
Mentor.
I didn't think of that, actually.
Thank you.
Thank you so much, everybody.
Thank you,
Good
madam.
night. Thank you,
Bye-bye.
Leela Kumar
Good
sir,
night.
for spending
Thank you,
your time.
madam.
Good night.
My pleasure. Good night.